Hi, everyone. Dr. Brooke Kolisiak here from Legacy Physical Therapy, and I am very excited today to be talking all things pelvic organ prolapse with nurse practitioner Julie Hake today from Washington University's program in female pelvic medicine and reconstructive surgery. That is a tongue twister to get all that out. I like it. So let me give you a little bit of an intro, and I am going to read. I apologize. I'm going to put it up here so I don't look awful with it. But so, like I said, Julie works in the division of female pelvic medicine and reconstructive surgery. This is also known as urogynecology. We'll probably talk a little bit about how this specialty sometimes can be hard to find, but is a gem of a resource to know about. She's at Washington University School of Medicine and has just begun her 15th year of employment. Congratulations. She started out in the field as a staff nurse, and she felt compelled to return to school and receive her doctorate in nursing practice, the DNP, in 2020 from the University of Missouri, St. Louis, and she has an emphasis in women's health. So with this degree, she's excited to reach out to patients on both the individual and community level, educating them on their various conditions. In her spare time, Julie enjoys spending time with her husband, 2 boys, and 2 yellow Labrador retrievers, as well as singing in the choir at church and hiking. So I did the formal introduction, but Julie, why don't you go ahead and introduce yourself to our audience and tell them a little bit more about yourself?
Again, my name is Julie Hake. I'm happy to be here with Brooke. She and I have had the pleasure of working together over the last several years. As Brooke said, I work at WashU at in the Division of Female Pelvic Medicine and Reconstructive Surgery, also FPMRS for short, aka urogynecology. We specialize in female pelvic floor disorders.
Wonderful. And what are some of those common disorders that you guys typically see in your office?
I'd say the most common disorders that we see are pelvic organ prolapse, urinary symptoms, and some bowel symptoms as well.
Wonderful. Well, and that's why today we're going to be talking about all things related to pelvic organ prolapse. Whenever at Legacy we have a patient who's coming to us with symptoms of heaviness, pressure, fullness, and bulging in the vagina, all of those, which we'll talk more about, we always recommend that they get seen by a urogynecologist, because you guys are definitely the experts in this area. And that's so tell us a little bit more about what is pelvic organ prolapse?
Pelvic organ prolapse is a weakness in the vaginal muscle walls that when they are weak, they can cause some protrusion. There's different degrees of prolapse, and it can give symptoms of pressure, heaviness, some urinary symptoms, and some bowel symptoms as well.
Gotcha. So let's walk through, because I think that's what's fascinating to me, is that the diagnosis or having pelvic organ prolapse can present so many different ways for different people. So can we kind of walk through, like, what are some of the urinary symptoms? What are some of the bowel symptoms, that kind of stuff? What are the different symptoms that people might be experiencing?
So, common urinary symptoms could be urgency, frequency of urination, or maybe trouble starting the stream of urine. Maybe even incontinence if there's a weakness in the front wall of the vagina. Other bowel symptoms could be difficulty in moving their bowels. It could be, feeling of incomplete emptying of the bowels, maybe needing to splint or reduce the bulge or splint in order to start or initiate a bowel movement.
Gotcha. I know you and I talk splinting all the time, and we know what that means, but why don't you elaborate a little bit on that for the general public who's like, I have to wear a splint? What?
Yeah.
What does that mean?
So some women will put some pressure on the posterior or back part of the vaginal wall or the tissue just in front of the rectum in order to initiate a bowel movement. And that's what we mean by splinting.
Gotcha. Yeah. So sometimes people are feeling that pressure kind of pushing. Honestly, a lot of times they describe it, it feels like the poop's going the wrong direction. Mm-hmm. Like it's pushing forward into my vagina and it's not coming out. And that can be a symptom of prolapse there. And sometimes supporting that back wall can make a big difference.
Yeah.
I think the bladder symptom that surprises a lot of our patients is we have some patients who had maybe been experiencing bladder leakage for years, and they maybe didn't do anything about it, thought it was kind of normal. They had babies and that, and they're like, oh, it's just, I'm supposed to have leakage. Well, that's a whole different conversation. But and then they develop pelvic organ prolapse, and all of a sudden their leakage is gone. Like that has changed. And I think that one's surprising to people, that they're like, wait a minute, I had leakage, then the prolapse, now I have pelvic organ prolapse, and now I don't have leakage. So can you elaborate a little bit more on how that one can happen? Because I think that one surprises people a lot of times.
Yes. So the way the female anatomy is, the way that I like to explain in more simplistic terms is that, and I will typically use my, hand as a diagram, and the way the vagina is, it's kind of like an upside down U. And in the front part of the vagina, that wall shares the same wall as the urethra and the bladder. So if the wall is weakened in the front part, it can actually kink the urethra, providing some symptom relief in regards to stress urinary incontinence, but it's kind of like kinking, for lack of a better analogy, like a garden hose. If you kink the hose, you're going to stop the flow of water. Same thing with urine. If the urethra is somewhat kinked, it's going to prevent that leakage.
Mm-hmm. Yeah. So, that's the same analogy I use, kink in the garden hose. So,
Yes.
And then outside of bowel and bladder symptoms, are there other common symptoms of prolapse that women will describe to you guys?
Depending on the severity, pressure, heaviness, like something's falling out of the vagina. If the tissue is protruding out of the vagina, it will feel like they're sitting on something, which can be uncomfortable and alarming. We have patients who, they think that maybe they've got a tumor coming out of their vagina. So they might be a little nervous and what is this? And then when they come to us and we kind of explain it's kind of a weakness in the vaginal wall, it kind of provides some reassurance.
That makes sense. Yes, we get that a lot. Like, I felt this bulge and I didn't know what it was. I thought, did I have a tumor? Like, is something going on that way? Yeah. And the other thing that people will say or think is, oh, my bladder's falling out or my rectum's falling out. And is that truly the case with prolapse?
So no, and I get that a lot as well. And so when I meet with patients for the first time and they feel that it's their bladder tissue that they're seeing coming out of the vagina or their rectal mucosa that is coming through the vagina. I have a better diagram in the office, but can show them, it is the vaginal tissue that is protruding. And in a way, it is a weakness in the muscle that has allowed or created a pocket, if you will, and the pelvic organ associated with that vaginal wall is what is prolapsing into that pocket.
Mm-hmm. I love to use the analogy of the sweater bump, of leaving a sweater on the hanger and having that bump push. And so I'm just seeing that, the vaginal wall is my sweater, but the hanger is whatever organ's behind that. So it's not, we're not seeing an organ actually come through. There's not a hole in the wall.
Exactly. And I think that can be very reassuring as well. Because some patients really may not have any symptoms at all, other than they know that they can see or feel tissue coming out of their vagina.
Yeah, that is very true. Well, what can cause prolapse? Why do women develop this?
So there are a variety of factors. It's very multifactorial in regards to what causes pelvic organ prolapse. Certain, lifestyle factors, chronic constipation be a risk factor for developing pelvic organ prolapse, excessive repetitive heavy lifting, as well as weight, especially abdominal weight, that can increase the risk of pelvic organ prolapse. History of childbirth, delivery, so those are all things that can increase the risk. Genetics is also an increased risk. So if your, mother, sister, grandmother, had prolapse, that might be a chance that you will too.
Yeah, I like to tell people you can't outrun the genetic card. Sometimes just what the consistency of your connective tissue is passed down from other generations, and so if you're dealing with issues, let's check up the chain and see what other family members. And I think that's surprising for a lot of people, because maybe this isn't an issue that they have talked about with family members, but then once they're experiencing it and they start to talk to sisters and mothers and grandmothers and aunts, and that's like, oh, I didn't realize this was something that our family's been dealing with.
And I think that too is important to talk about it with a trusted friend or family member. It's very common to feel like you're the only one, and you're not the only one. It's a common disorder, and it can be very helpful to talk about it, especially with someone who's experiencing it maybe at the same time as you are.
That is very true. So what if a patient thinks, based on the symptoms that we're talking about here, that if they think that they are experiencing pelvic organ prolapse, what should they do about it?
Well, first and foremost, I always like to say, do not panic. Secondly, give us a call. There are, we can do a very detailed pelvic organ support exam to assess where the support is, and then, kind of go through what the options for management are.
Gotcha. And that, let's break that down a little bit more into a subset that we see very commonly at Legacy Physical Therapy. It's that postpartum mom who's feeling a lot of heaviness or pressure. Maybe she just had a vaginal delivery 2, 4 weeks, 6 weeks ago, even up to a couple months ago, and they're starting to feel that symptoms of that heaviness or pressure. And that, how is that different or similar to kind of the general population who are experiencing these symptoms?
So, we do see patients who have that pressure or heaviness. It feels like something's falling out of the vagina. Then we do an exam, and they have overall, normal or good support. In which case, then that's when we assess the muscles of the pelvic floor. And, we may find some tenderness or incoordination of those pelvic floor muscles, which are more than likely responsible for those symptoms of pressure and heaviness. And then that's where we refer to you.
Yes. Might have been a little leading question, but it's very true. We get a lot of postpartum moms who are like, I'm Googling stuff. Based on what I'm feeling, I think I have a prolapse. And like you said, we recommend they go and get assessed, and then we get assessed and find out, no, actually your support structures are in place. It's just that everything got a nice big stretch to it, and things aren't supporting, the muscles aren't supporting as well as they could be right now, and are potentially causing the problem. So.
Yeah, and we even see other women who, they might be, depending on their occupation, if they do a lot of sitting or lifting or certain body mechanics, that can be, kind of hard on the pelvic floor, if you will. They too will come into us with pressure, heaviness, and again, they might have really normal or good support, and then refer them to pelvic floor physical therapy to rehabilitate those muscles.
That makes sense. So we've just talked a little bit about pelvic physical therapy can be an option to help with people experiencing prolapse symptoms. What are some treatment options if we truly identify that this person is experiencing pelvic organ prolapse? What can they do about it?
So, if someone is experiencing pelvic organ prolapse, there are in general three options for managing pelvic organ prolapse. One being expectant management, essentially, being, diagnosed with prolapse, saying yes, this is what you have, and then just kind of monitoring symptoms. That woman may or may not be, very symptomatic, but they just feel reassured knowing that what they have, or think they what they have, that's something more serious. Then we might just follow them every a few months or so for a year or whatnot, just to make sure that they're emptying their bladder okay and whatnot, and follow up on symptoms. If a patient is symptomatic, they are experiencing those symptoms of pressure, heaviness, having some urinary or bowel symptoms, and they are looking for some form of intervention. We will refer to pelvic floor physical therapy. We're very clear that it is not curative in regards to reversing pelvic organ prolapse, but it can help with symptoms of pelvic organ prolapse. Other conservative management options include Pessaries. A pessary is a vaginal support device that sits in the vagina. Again, it's not curative in the sense that it would reverse prolapse, but it can, again, provide a lot of symptom relief for women who may not want the next option, which would be surgical intervention.
And with surgical intervention, and that, are there certain time frames or clusters of symptoms that you're looking for where the surgical intervention is going to be like, yeah, this is the route that we should go, or are there times where it's better to wait and see with it? How do you and the patient determine that for them?
So, the way I like to explain to patients is that we are a very quality of life driven specialty. So if she is coming into us and greatly bothered by her symptoms, not interested in conservative options, then we can talk about, whether or not surgery would be right for her. But we also have patients that, want to exhaust all other options before proceeding with surgery. And sometimes we do, it's more often than not that we can find some form of conservative management before going to surgery. But there are times where sometimes a woman may come to us when we've exhausted all the pessaries, and then it's discussion of the different surgeries that are available.
Well, I'd like to talk a little bit more about pessaries, because I honestly think they get a bad rap, and that if people know about them at all, they think they're just this thing for little old ladies. Yeah. And I wholeheartedly disagree with that. And I think they can be so helpful for women of all ages dealing with prolapse symptoms. So you already told us a little bit about pessaries, but tell us a little bit more, and maybe how someone gets fit for them, that kind of stuff.
Yeah, absolutely. So you're absolutely right. Pessaries are not just for your grandmother or mother or whatnot. They are a great way, a great conservative way to manage prolapse. And they're even a great way to manage prolapse for women who think that they want surgery in the future, but are not, the timing just isn't quite right just yet. So it can definitely be used as a bridge or a crutch, if you will, until surgery is an option and timing is right. So pessary is a silicone rubber device that comes in different shapes and sizes. I wish I had a picture to show, but we do have two very common types of pessaries. The most common type of pessary that we use looks like a ring. And what it does is it provides support to the anterior and top wall of the vagina. The majority of it is to the front wall of the vagina. Again, it is placed in the vagina, and it's something that a woman can take in and out herself to manage. Or if they are not able to, it's something that they would go and see a urogyn provider or even a gynecologist to remove every 3 months or so to clean and replace and just assess that it's the right size. And in regards to sizing of a pessary, That does entail an internal exam where the provider gauges what size might be best as far as a pessary goes. I like to kind of set expectations up front with the patient that it is very much a trial and error process, meaning that, what might work great in the office setting before she leaves, once the true test is going to be how it works out in the real world when they're doing their regular activities. And if it doesn't work quite right, that doesn't mean that's a pessary a pessary is not going to work. We might need to adjust the size or the shape.
Yeah. No, that makes sense. I tell people a lot of times, I equate it to, I sprained my ankle a lot when I played sports as I was younger, and I'm pretty sure I'm still missing some ligaments on the side of my left ankle from that. So it feels very loosey-goosey on me. And so if I'm going to play tennis or basketball or something that involves a lot of movement and cutting, I always put an ankle brace on. So it's my support for my ankle so that I can do the activities that I want to do. And that's how I describe the pessary for the vagina. I was like, this is a support device to help the tissue be in a good place so that you can work out and be active the way you want to and not be symptomatic with it.
Absolutely. And that's a perfect way, we do have some women that will just use the pessary as needed when they're doing certain activities where they're most symptomatic of their prolapse.
And actually, Julie, I have to find the citation for you, but there have been a couple recent research studies that have shown that the use of pessary to just help support the tissue back up into the vaginal canal in a good position has actually helped to improve the prolapse sum itself, as well as improve the muscle and the support structures because everything's being worked out and used in its right position. So I was reading that article. I was like, oh, that's very fascinating. So it's not a fix, but it does, help support the tissue and let it work in its correct anatomical position, I guess is a good way to put it.
Yeah, and there is some muscle memory too. I mean, I have patients that will take their pessary out, and then, while it's out, their prolapse may or may not, protrude, but there may be certain activities, they're like, oh yeah, there it is again. And then they just go back to using their pessary. So that makes sense.
So with pessaries, do patients usually manage them on their own? How long can they use them for? Like, how does that work?
So in an ideal situation, we would have a patient manage their own pessary. Again, like I mentioned before, a pessary is a very safe and conservative way of managing prolapse. One of the main risks is that sometimes it can cause or put some pressure on the tissue and sometimes cause a sore. So to help to decrease that risk, we would ideally have women take it out at night, leave it out, and then put it back in the next morning. But we do have some patients that are not able to do that, in which case, as long as they have someone that they're going to see regularly to take the pessary out, inspect the tissues, and make sure there's no sores, then that is another way.
Wonderful. Very cool. And would you say with your patients who kind of go this more conservative route, do you feel like it's an either or situation, like they're doing pessaries or they're doing pelvic physical therapy, or are they usually doing a combination of it? How does it typically work for your patients that get the most success?
So I feel that the patients that get the most success will do both when they're doing both together. Because I have found too that, while pessaries are comfortable, some patients might be a little bit more aware that it's there in the beginning. And pelvic floor physical therapy, I've seen patients can increase the tolerability of the pessary if there is any, again, it shouldn't be uncomfortable, but, they might become less aware that it's there if those muscles are being worked on.
Gotcha. Oh, that makes sense. Very cool. Well, you have shared a wealth of information with us today about prolapse and its management and the different types of treatments, all that kind of stuff. Are there any kind of parting words you want to share with the audience about, well, it doesn't have to be about prolapse, but it could be.
If in doubt, be seen, we're happy to see you for prolapse, and, kind of, have that discussion in regards to, a little bit more detailed conversation about, your specific prolapse. I love to talk things pelvic floor, so, and enjoy the education aspect of things as well.
And I'm going to throw one more question in there because it's something I thought of, and that, so if a woman has already spoken with her OBGYN about this, but is still dealing with prolapse-like symptoms or that, and they're not happy with the symptoms that they're feeling, should they reach out and contact a urogynecologist or a women's health nurse practitioner in this type of practice? And why would that be a good next step for them?
I think it's great to hear a different perspective. So I do think that would be certainly worth a conversation. It's good to know what all the options are for one's particular condition, because it might be, again, like a multifactorial issue. If there's some pelvic floor muscle dysfunction in conjunction with prolapse, it might, entail a more multidisciplinary approach where they're working with both us and a physical therapist. And it can also be, reassuring to know, also, we fit a lot of pessaries. So we do see some patients too that have maybe tried a pessary at another office, but, we do have, for example, a lot of pessaries, and so, it could just be a trial of a different shape or type of pessary as well.
Gotcha. Well, great to know that. Well, you guys are a wonderful resource there. So we're so glad to have you. And I've been sharing along the way how to get in touch with you if someone thinks that they should come see you guys at the office there. But anyone out there, if you have questions after watching this, I'll be watching the Facebook feed for a while and seeing if there's any questions. I'll make sure that Julie or myself can answer them for you. So if you do have questions that you want to ask, just put them in the comments and we will answer them. But we appreciate, Julie, you taking time out of your day to come talk with us, and we appreciate those of you who are watching the video. So thank you so much.
Thank you for having me.